Okay, let's unpack this. Have you ever, really stopped to think about what keeps everything inside you balanced?
It's pretty amazing, isn't it? Like a super complex chemical balancing act.
Exactly, like something engineers would struggle with. So today, on the deep dive,
We're diving into the urinary system.
yeah, especially those workhorses, the kidneys, we're digging into a key chapter from Human Anatomy and Physiology, the 10th edition.
Our goal is, to really get a handle on it quickly. Anatomy, physiology.
How it works, why it's so vital, maybe some surprising bits too.
Yeah.
Connecting it all back to, well, you.
What's truly fascinating, I think, is that your kidneys filter nearly 200 liters of fluid every single day.
200 liters.
Seriously. Yeah, from your bloodstream. Imagine a super efficient, water purification plant running constantly inside you.
Wow.
It's always letting toxins, metabolic wastes, excess ions leaving your urine.
But it keeps the good stuff.
Meticulously returns needed substances back to the blood. It's this constant chemical balancing act. Absolutely crucial.
So it's not just filtering waste out.
Oh, no. It's regulating your total water volume. The concentration of solutes osmolality, we call it. Ion levels, too.
Ion levels.
We have potassium. Even tiny shifts in potassium can be really dangerous, potentially fatal.
Okay, that's critical.
And there's more. Long-term acid-base balance, getting rid of drugs and other foreign stuff.
They produce things too, right?
Absolutely. Hormones like erythropoietin that tells your body to make red blood cells. And renin, which is key for blood pressure.
I didn't know about the red blood cell link.
Yep. They even activate vitamin D and can perform gluconeogenesis, making glucose if you're fasting for a long time.
Incredible multitasking organs, really. But they're not alone, are they?
Right. It's a whole system. The kidneys are the main processors, you could say.
And then the ureters.
Exactly. Two tubes, the ureters, carry the urine down to the urinary bladder.
Which is just temporary storage.
Yeah, storage tank. And finally, the urethra is the tube leading out of the body. It's all integrated.
Okay, so location. Where are these super filters actually sitting?
They're kind of tucked away. Retroperitoneal.
Retro.
Yeah.
Behind the peritoneum. That lining in the abdomen.
Exactly. Against your back muscles, high up in the lumbar region, sort of protected by your lower ribs.
And one's lower than the other.
Yeah, the right one usually sits a bit lower. Your liver pushes it down slightly.
Okay. And size-wise?
About the size of a large bar of soap. Around 150 grams each.
Not huge,
Yeah.
but they do so much. And there's that notch on the side.
That's the renal hilum. It's the gateway, where the renal artery, vein, ureter, nerves, lymphatics all go in and out.
Makes sense. Like a connection hub.
And protecting these vital organs are 3 layers of tissue. Think of it like packing material.
3 layers, okay.
Outer layer is the renal fascia, tough connective tissue that anchors them.
Anchors them, so they don't move around.
Right. Then there's a middle layer, the perirenal fat capsule. That's the cushion.
Literally a cushion. Against bumps and stuff.
Exactly. And then the innermost layer, the fibrous capsule, is a transparent membrane that helps prevent infections from spreading to the kidney.
That fatty layer sounds important.
It really is. Clinically, if someone loses a lot of weight very rapidly, that fat can shrink.
Oh, right.
The kidney can actually drop. They call it renal aposis.
Kidney drop. What happens then?
The ureter can get kinked, urine backs up, potentially causing severe kidney damage, hydronephrosis. Shows how vital that fat cushion is.
Okay, wow. So that's the outside. Now, if we sliced one open, you mentioned distinct regions.
Yes, it gets really interesting inside. 3 main parts. You've got the outer renal cortex. It's lighter in color, looks kind of granular.
The cortex, okay. Like the bark of a tree.
Sort of, yeah. Then deeper is the renal medulla. Darker, reddish-brown.
Medulla.
And the medulla contains these cone-shaped structures called renal pyramids.
Pyramids? What do they look like that?
They look striped because they're full of parallel bundles of tiny urine-collecting tubules and capillaries.
Got it. And between the pyramids.
Those are renal columns, basically inward extensions of the cortical tissue, separating the pyramid.
Okay, cortex, medulla, with pyramids and columns.
Mm-hmm.
Where does the urine go from there?
It collects in the renal pelvis. It's like a funnel-shaped tube right near the hilum, and it's continuous with the ureter.
The funnel.
And branching off the pelvis are these cup-like structures, the calyces minor ones, collecting from the pyramid tips, merging into major ones.
The calyces, like little collecting cups.
Exactly. They collect the urine and then use smooth muscle contractions, peristalsis, to propel it down towards the bladder.
A very organized flow path.
It truly is, but even these internal parts can have issues. Infections can happen just in the pelvis and calyces, that's pyelitis.
Just the collecting parts.
Yeah, but if the infection spreads to the whole kidney, it's pyelonephritis. More common in females, unfortunately, often from bacteria migrating up.
Is it serious?
It can be, if untreated, potentially causing scarring and damage. But usually antibiotics clear it up effectively, it just needs prompt attention.
Right. Now, you mentioned filtering 200 liters. That must mean a massive blood supply.
Absolutely massive. About a quarter of your heart's output every minute flows through your kidneys. Over a liter of blood per minute.
Wow. A quarter of all blood flow.
Yeah, they're incredibly vascular. The renal arteries bring blood in, branching smaller and smaller.
Right.
Segmental interlobar, arcuate, cortical radiate arteries.
Okay, lots of branches.
Leading to the tiny afferent arterioles that feed the filtering units. And interestingly, over 90% of that blood goes to the cortex.
Where the filtering happens mainly.
Exactly. Then the filtered blood leaves through a reverse pathway of veins, cortical radiate, arcuate, interlobar, finally the renal vein, draining into the vena cava. No segmental veins, though, interestingly.
And nerves control this.
Yep, the renal plexus autonomic nerve fibers. They mainly adjust the diameter of those renal arterioles, influencing blood flow and thus urine formation.
Okay, let's zoom right in then to the actual filtering units, the nephrons.
The nephrons. Yes, the true workhorses. Over 1 million in each kidney. These are the structural and functional units.
There's 1 million tiny factories per kidney.
Pretty much. Each nephron, plus the collecting duct it drains into, carries out the processes of forming urine. It has two main parts.
Which are?
The renal corpuscle, which is in the cortex, and the renal tubule, which starts in the cortex, dips down into the medulla, and then comes back to the cortex.
Okay, corpuscle first. What's in there?
That's where the initial filtering happens. It contains the glomerulus.
Glomerulus sounds like a little ball.
It is a little ball of capillaries, a tuft really, but these aren't ordinary capillaries. They're fenestrated full of pores. Super porous.
For filtering.
Exactly. Allows large amounts of fluid and small solutes, but not proteins or cells to pass out of the blood. This fluid is the filtrate.
The raw material for urine.
Precisely. And surrounding this glomerulus is the glomerular capsule, or Bowman's capsule, cup-shaped.
Like it's catching the filtrate.
Exactly. It has an outer structural layer and an inner layer made of these amazing cells called podocytes.
Podocytes. Foot cells.
Yeah, they have these foot processes that wrap around the capillaries, leaving little gaps called filtration slits. That's where the filtrate enters the capsule space.
So, super specialized for filtering.
Highly specialized. Now, that filtrate enters the renal tubule.
Which is that long, winding tube, about 3 centimeters long.
That's the one. It has 3 major sections, each with a specific job and distinct cell types.
Okay, what's first?
The proximal convoluted tubule, or PCT, it's right after the capsule, highly coiled. Its cells are packed with mitochondria for energy.
And they have that fuzzy border.
The brush border, yes, dense microvilli. Massively increases surface area. This is where most of the reabsorption happens, pulling back water, glucose, amino acids, ions, and some secretion too.
Main reclamation zone.
Then the filtrate enters the nephron loop, or loop of Henle. It's U-shaped, dips down into the medulla.
With a down part and an up part.
A descending limb and an ascending limb. They have different permeabilities to water and salt. This difference is crucial for the kidney's ability to concentrate urine. We'll come back to that.
Okay, the loop is for concentration. What's the last part of the tubule?
The distal convoluted tubule, or DCT. Coiled again, but its cells are thinner, fewer microvilli. This is more about fine-tuning the filtrate, often under hormonal control.
Fine-tuning. Like final adjustments.
Exactly. Then, the filtrate from several DCTs grains into a collecting duct.
Collecting ducts run through the pyramids, right? Giving them that striped look.
That's right. The collecting ducts have 2 main cell types. Principal cells, managing water and sodium balance, and intercalated cells, handling acid-base balance. They make the final adjustments and carry urine towards the renal pelvis.
Got it. Now, you mentioned different types of nephrons earlier.
Yes, 2 main classes. Most, about 85%, are cortical nephrons. They're mainly in the cortex, have short nephron loops.
Cortical nephrons? The standard one.
Pretty much. But the other 15% are juxtamedullary nephrons.
Juxtamedullary.
Yeah.
Near the medulla.
Exactly. They sit close to the cortex-medulla junction, and crucially, they have these really long nephron loops that extend deep into the medulla.
And these are the key ones for concentrating urine.
They are absolutely essential for that. Now, about their blood supply, It's also specialized.
Okay.
The glomerulus, as we said, is fed and drained by arterioles. This keeps the pressure high, perfect for filtration.
High pressure filter.
Then the arteriole leaving the glomerulus gives rise to the peritubular capillaries. These are low-pressure porous capillaries that cling closely to the renal tubule.
Or reabsorption. Take a step back.
Precisely. They readily absorb the solutes and water reclaimed by the tubule cells.
And the juxtamedullary ones have something different. The vasorecta.
Yes. The efferent arterioles of juxtamedullary nephrons form the vasa recta, long, straight vessels that run parallel to those long nephron loops deep in the medulla.
Why parallel?
They supply oxygen and nutrients to the medulla, but more importantly, they play a crucial role in forming concentrated urine by helping maintain that medullary osmotic gradient. They act as countercurrent exchangers.
Countercurrent. We'll get to that. One more structure first.
Yeah.
The JGC.
Ah, yes, the juxtaglomerular complex, or JGC. It's a really important little structure where part of the DCT lies right up against the afferent arteriole feeding its own glomerulus.
A control point.
A critical one. It has specialized cells. Macula densa cells in the tubule act like chemoreceptors, monitoring the NaCl concentration of the filtrate flowing past.
Sensing salt levels.
Yeah. And in the arteriole wall are granular cells, or JG cells. They're mechanoreceptors sensing blood pressure in the afferent arteriole, and they contain granules of renin.
Renin for blood pressure regulation.
Exactly. And there are other cells kind of bridging the gap, passing signals between the macula densa and granular cells. So the JGC acts as a sensor and control system for filtration rate and blood pressure.
Okay, that's a lot of intricate machinery. Let's put it together. The 3 big steps in making urine.
Right. Think of it as a 3-step process. First, glomerular filtration. Basically, dump everything small out of the blood into the tubule, creates the initial filtrate.
Step 1, dump cell-free, protein-free filtrate.
Step 2, tubular reabsorption. Reclaim almost everything the body needs back from that filtrate into the blood. Glucose, amino acids, most water, salts.
Step 2, reclaim. Super selective. 99% of water and salt gets pulled back.
About that, yes. It's incredibly efficient. And finally, step 3, tubular secretion. Selectively add certain wastes or excess ions from the blood into the filtrate.
Step 3, fine-tune or selectively add waste.
That's a good way to put it. So dump, reclaim, fine-tune, and the scale is just immense. 180 liters filtered daily.
Daily, like what, 1.5 liters of urine produced?
Around that, yeah. Less than 1%. And it takes a huge amount of energy. Those kidneys use 25% of your body's oxygen at rest just for this.
Wow. Okay, let's dive into step 1, glomerular filtration. That filter membrane sounds key.
It is. It's incredibly permeable to water and small solutes, but normally impermeable to large molecules like proteins and certainly blood cells. It has 3 layers.
The pores in the capillary, the basement membrane.
Right, the fenestrated endothelium. Then the basement membrane, which is fused and has a negative charge to repel proteins. And finally, the podocytes with their filtration slits.
So it's physically small pores plus an electrical barrier.
Exactly. Very effective. Which is why seeing proteins or blood cells in urine usually signifies a problem the filter's damaged.
What actually pushes the fluid through? You mentioned pressure.
Yes, it's driven by pressures. The main outward force is the hydrostatic pressure in the glomerular capillaries, the HPGC. It's about 55 millimeter Hg, which is quite high for a capillary bed.
High pressure pushes fluid out. What pushes back?
2 forces push back, opposing filtration. One is the hydrostatic pressure in the capsular space, the HPCs, about 15 millimeter Hg, the fluid already in the capsule pushing back. The other is the colloid osmotic pressure in the glomerular capillaries, the OPGC, about 30 millimeter Hg. This is the pull exerted by the proteins still in the blood, trying to draw water back in.
So outward push minus the 2 inward forces.
Exactly. Net filtration pressure, or NFP, is HPGC minus HPCs plus OPGC, so 55 minus 15 plus 30 gives you about 10 millimeter Hg.
Only 10 millimeter Hg, that seems small.
It does, but remember how incredibly permeable that membrane is and the huge surface area? That 10 millimeter Hg pressure is enough to produce 125 milliliter of filtrate per minute. That volume is the glomerular filtration rate, or GFR.
GFR, 125 millimeter.
And that needs to stay pretty constant.
Ideally, yes. Too high, and you lose needed substances too low and waste isn't adequately removed, so GFR is tightly regulated.
By those intrinsic and extrinsic controls you mentioned.
Exactly. Intrinsic controls, or renal autoregulation, are the kidney's way of maintaining a nearly constant GFR despite moderate fluctuations in systemic blood pressure, say between 80 and 180 millimeter Hg arterial pressure.
How does it do that locally? Two main ways. The myogenic mechanism. The smooth muscle in the afferent arterial wall responds directly to stretch. If blood pressure rises, it stretches, and the muscle constricts, restricting flow and keeping GFR stable. If BP drops, it dilates.
Automatic adjustment. What's the other one?
Tubuloglomerular feedback. That involves the JGC we talked about. The macula densa cells monitor the NaCl concentration in the filtrate.
Salt levels again.
Right. If GFR is too high, filtrate flows too fast, less time for reabsorption, so NaCl concentration is high when it reaches the macula densa.
High salt means too fast.
Yes. So the macula densa releases signals that cause the afferent arteriole to constrict, slowing blood flow, reducing GFR back to normal. If NaCl is low, it signals dilation to increase GFR. Clever feedback loop.
Very clever. But sometimes the body needs to override this, extrinsic controls.
Exactly. If your systemic blood pressure drops significantly, like in hemorrhage, the priority shifts to maintaining overall blood pressure, even at the expense of GFR.
Survival mode.
Pretty much. The sympathetic nervous system kicks in strongly. It causes constriction of afferent arterioles, which decreases GFR, helps conserve body fluid volume, and redirects blood to vital organs.
Makes sense. And the renin system.
The renin-angiotensin-aldosterone mechanism, crucial. Low blood pressure triggers the granular cells in the JGC to release renin.
Triggered by sympathetic nerves, or the macula densa sensing low salt, or just less stretch on the arteriole.
All of the above can stimulate renin release. Renin sets off a cascade producing angiotensin II.
Angiotensin II. That's a powerful vasoconstrictor.
Very powerful. It also stimulates aldosterone release from the adrenal cortex. Aldosterone makes the kidneys reabsorb more sodium, and water follows, increasing blood volume and pressure. So it's a major blood pressure regulator.
So multiple layers of control. What if GFR drops too low for too long?
That can lead to anuria, very low urine output. It might indicate dangerously low glomerular pressure or renal failure. If the kidneys fail, wastes build up in the blood, a toxic condition called uremia.
Uremia, urine in the blood.
Essentially, yeah. It affects multiple organ systems and requires treatment like hemodialysis, using an artificial kidney machine, or a kidney transplant.
Okay, that covers filtration. Now, step 2, tubular reabsorption. Pulling the good stuff back.
Right. This is where about 99% of the filtrate volume gets reclaimed. It's highly selective. Some things move right through the tubule cells, the transcellular route.
Through the cells.
Others move between the cells, through leaky tight junctions, especially in the PCT, the paracellular route.
Between the cells. And it takes energy. Active transport.
Some of it does, yes. Active reabsorption requires ATP, usually to move substances against their concentration gradient. But a lot is passive, driven by electrochemical gradients or osmosis.
And sodium is the key driver here.
Absolutely central. Sodium ions, Na+, are the most abundant solute in the filtrate. Actively pumping Na+ out of the tubule cell at its basolateral membrane, the side facing away from the filtrate, using the Na+, K+ AT paste pump, uses about 80% of the energy for active transport in the kidneys.
Pumping sodium out creates a gradient.
A very strong electrochemical gradient. This low Na+ concentration inside the cell then pulls Na+ in from the filtrate side, the apical membrane.
Downhill flow into the cell.
Exactly. And this downhill movement of Na+ is coupled to the transport of many other substances. It drives the secondary active transport of glucose, amino acids, vitamins, other ions. They get a free ride with sodium.
So transport. Sodium pulls them along.
Precisely. And all this solute movement makes the filtrate less concentrated than the surrounding tissue fluid. So water follows passively by osmosis, moving through water channels called aquaporins.
Water full of salt.
The classic rule. We call water reabsorption that's coupled to solute reabsorption obligatory water reabsorption. It happens mainly in the PCT. Later in the collecting ducts, water reabsorption can be regulated by hormones. That's facultative water reabsorption.
Obligatory versus facultative. Okay, what about other things?
As water leaves, other solutes like lipid-soluble substances, some ions, and urea become more concentrated in the remaining filtrate, so they tend to follow their concentration gradients and get passively reabsorbed too.
So sodium drives almost everything else. Is there a limit?
Yes, that's the transport maximum, or TEAM. For substances needing a protein carrier, like glucose, there are only so many carriers available.
Like gates in a fence.
Good analogy. If the concentration of the substance in the filtrate is too high, all the carriers get saturated and any excess just stays in the filtrate and gets excreted in the urine.
Like glucose and diabetes.
Exactly. In uncontrolled diabetes mellitus, blood glucose is so high that the amount filtered exceeds the TM for glucose reabsorption, so glucose spills into the urine.
Okay, so different parts of the tubule reabsorb different things.
They specialize, yes. The PCT is the main reabsorber. It takes back all the glucose and amino acids, about 65% of the sodium and water, most bicarbonate, potassium, fluoride, and about half the urea. Bulk reabsorption happens here.
PCT does the heavy lifting. Then the nephron loop.
The loop is different. The descending limb is permeable to water, but not very permeable to solutes. So as filtrate goes down into the salty medulla, water leaves, concentrating the filtrate.
Water out, filtrate gets salty.
Then the ascending limb is impermeable to water, but actively pumps out Now plus and Cl. So as filtrate goes up, salt leaves, making the filtrate dilute again, but contributing salt to the medulla.
Water out, then salt out. That
Yeah.
sounds important for that concentration thing.
Absolutely vital. We'll link it all up with the countercurrent mechanism soon.
Okay. Then the DCT and collecting duct, fine-tuning time.
Exactly. Reabsorption here is fine-tuned by hormones based on the body's needs.
Like ADH, antidiuretic hormone.
Yes, ADH makes the principal cells of the collecting ducts more permeable to water by causing aquaporins to be inserted into their membranes. When ADH levels are high, like when you're dehydrated, lots of water is reabsorbed, producing concentrated urine. Low ADH, when overhydrated, less water reabsorbed, dilute urine.
ADH controls water output. What about aldosterone?
Aldosterone targets the DCT and collecting ducts, primarily increasing the reabsorption of sodium. Water follows sodium, so this increases blood volume and pressure. Aldosterone also increases potassium secretion.
So aldosterone manages sodium and potassium balance, influencing blood pressure.
Correct. Then there's atrial natriuretic peptide, AMP, released by the heart when blood pressure is high. It does the opposite of aldosterone, inhibits sodium reabsorption, promoting salt and water loss to decrease blood volume and pressure.
AMP lowers blood pressure. Any others?
Parathyroid hormone, PTH, acts mainly on the DCT to increase the reabsorption of calcium when blood calcium levels are low.
Okay, a lot of hormonal fine-tuning. Now, step 3, tubular secretion. Adding stuff to the filtrate.
Right. Reabsorption in reverse. Moving substances from the blood of the paratubular capillaries or from the tubule cells themselves directly into the filtrate.
Why do we need this step? Didn't we filter stuff out already?
Several reasons. First, disposing of substances tightly bound to plasma proteins, like certain drugs or metabolites which weren't filtered easily.
Okay, stuff that slipped through the initial filter.
Second, eliminating undesirable substances that were passively reabsorbed, like urea and uric acid. Kind of a second chance to get rid of them.
Cleaning up anything reclaimed by mistake.
Third, getting rid of excess potassium ions, K+. Aldosterone promotes Na+ reabsorption, but also K+ secretion in the collecting ducts.
Managing potassium levels, critical.
And fourth, controlling blood pH. The tubules can secrete excess hydrogen ions, H+, into the filtrate to make the blood less acidic.
Yeah.
They can also generate and reabsorb bicarbonate, HDO3, the main buffer. So secretion is key for acid-base balance.
Okay, filtration, massive reabsorption, and targeted secretion. Now, how does the kidney make urine super concentrated sometimes and watery other times? That countercurrent thing.
Exactly. The kidney's ability to vary urine concentration depends on the osmotic gradient in the medulla and the countercurrent mechanisms that establish and maintain it.
Osmotic gradient, meaning it gets saltier, deeper in the kidney.
Precisely. The concentration goes from about 300 milliosmoles, MOSM, similar to plasma, up to 1200 milliosm deep in the medulla. This gradient is key.
And the long loops of juxtamedullary nephrons create this, the countercurrent multiplier.
Yes. Remember the loop's different permeabilities. Filtrate flows down the descending limb, water leaves passively into the salty medulla, making the filtrate inside very concentrated, maybe 1200 milliosm at the bottom.
Water out, filtrate concentrates.
Then, filtrate flows up the ascending limb, which actively pumps salt out into the medulla, but is impermeable to water. This makes the filtrate dilute again, maybe 100 millism by the top, but crucially, it adds salt to the medulla, maintaining the gradient.
Salt pumped out keeps the medulla salty. And the flows are in opposite directions.
Opposite directions countercurrent flow. This interaction multiplies the concentration effect, building that steep gradient. That's the countercurrent multiplier.
Okay, the loop builds the gradient. What preserves it? The vasa recta.
Yes, the vasa recta act as the countercurrent exchanger. Blood flows slowly down into the medulla. picking up salt and losing water. Then it flows back up, losing salt and picking up water.
So it delivers blood but doesn't wash away the salt gradient.
Exactly. The blood leaving is nearly the same concentration as the blood entering, but it's exchanged solutes and water, preserving that crucial medullary gradient established by the loops.
Clever. So gradient established and preserved. How does the collecting duct use it?
This is where ADH comes back in. The collecting ducts run down through that salty gradient. If ADH levels are high, dehydration, aquaporins are inserted. Water is osmotically pulled out of the filtrate in the collecting duct into the hyperosmotic medulla.
Water leaves the duct, urine gets concentrated, up to 1,200 millism.
Potentially, yes. Very concentrated urine conserving body water. If ADH levels are low, overhydration, the collecting ducts stay impermeable to water. Water stays in the filtrate, producing large volumes of dilute urine, maybe as low as 100 millism.
So ADH is a final switch controlling concentration using the gradient.
Precisely. And urea actually plays a role too. ADH increases urea recycling from the collecting duct back into the medulla, which helps strengthen that deep medullary gradient even more.
Urea helps make it salty deep down.
Okay.
What about things that make you produce more urine? Diuretics.
Right. Diuretics are substances that enhance urinary output. Alcohol inhibits ADH release, leading to dilute urine. Caffeine has a mild diuretic effect too.
Coffee and beer.
Yeah. Then there are medical diuretics. Loop diuretics like furosemide, Lasix, are very potent. They inhibit salt transport in the ascending limb, disrupting the gradient. Thiazides act on the DCT. Osmotic diuretics are substances not reabsorbed that carry water out with them, like the high glucose in diabetes.
Different ways to increase water loss. Okay, how do we actually check if the kidneys are working well?
Clinically, we often look at blood markers like creatinine and BUN, blood urea and nitrogen.
Right.
But a more direct measure of kidney function is renal clearance.
Renal clearance, what's that?
It's the volume of plasma from which the kidneys completely clear a particular substance in a given time, usually a minute. The formula is C equals UVP.
UV over P.
U is the concentration of the substance in urine, V is the flow rate of urine formation, and P is the concentration of the substance in plasma.
What does it tell you?
It's used to determine the GFR. If we use a substance like inulin, which is freely filtered but neither reabsorbed nor secreted, its clearance is the GFR, about 125 millimillimet.
Inulin is the gold standard.
Yes. If a substance's clearance is less than inulin's, it means it's being reabsorbed, like urea, C is about 70. If it's equal, no net reabsorption or secretion. If it's greater than inulin's, it means it's being actively secreted into the tubules, like penicillin or creatinine, C is about 140.
So clearance values reveal how the kidney handles different substances. Creatinine is used often.
Yeah, creatinine clearance is a common clinical estimate of GFR. It's naturally produced waste, though its slight secretion makes it slightly overestimate GFR compared to inulin. Still very useful.
And low clearance or GFR indicates problems.
Definitely. Chronic renal disease is often defined as a GFR below 60 milliriemen for 3 months. Renal failure is typically GFR below 15 milliriemen, leading to uremia and the need for dialysis or transplant.
Okay, let's talk about the final product. Urine itself. What's normal?
Normally, it's about 95% water, 5% solutes. The main solute by weight is urea from protein breakdown. Others include uric acid, creatinine, and various ions like sodium, potassium, phosphate, sulfate. Depends a bit on diet.
And physically. Color, smell.
Color ranges from pale yellow to deep amber, depending on concentration. The yellow is due to urochrome, a pigment from hemoglobin breakdown. Cloudy urine might suggest a UTI.
An odor.
Fresh urine is slightly aromatic. If it stands, bacteria metabolize urea to ammonia, giving it that ammonia smell. Certain diseases or foods can alter the odor too, like asparagus, or the fruity smell of ketones in diabetes.
What about pH and concentration?
pH is usually slightly acidic, around 6, but can range from 4.5 to 8.0 depending on diet and metabolism. Specific gravity, which compares its density to water, indicates solute concentration, normally ranging from 1.001 to 1.035.
And things that shouldn't be there.
Right. Abnormal components are key diagnostic signs. Glucose, glycosuria, usually means diabetes. Proteins, proteinuria, suggest glomerular damage or high blood pressure. Ketone bodies, ketonuria, indicate starvation or diabetes.
Blood.
Hemoglobin. Hemoglobinuria could be from transfusion reactions or severe burns. Erythrocytes, actual red blood cells, hematuria, point to bleeding in the urinary tract. Leukocytes, white blood cells, or pus, pyuria, indicate a UTI. Bile pigments suggest liver disease.
So urine analysis is a powerful diagnostic window.
Absolutely. A simple urinalysis can tell you a lot about overall health.
Okay, Urine is formed, now it needs to get out. The transport system. Ureters first.
Yes, the two ureters are slender tubes about 25–30 centimeters long, running from the renal pelvis down to the bladder. They enter the back of the bladder at an oblique angle.
Oblique. Why?
This helps prevent backflow of urine into the ureters when the bladder contracts. They propel urine via peristalsis, rhythmic waves of smooth muscle contraction in their walls.
Like the digestive tract pushes food.
Similar principle, yeah. The ureter wall has 3 layers. Inner mucosa with transitional epithelium that can stretch, a middle muscularis with smooth muscle, and an outer fibrous adventitia.
And these can get blocked.
Yeah.
Kidney stones.
Exactly. Renal calculi, or kidney stones. Crystallized mineral salts, usually calcium oxalate. Most are tiny and pass unnoticed. But larger stones can lodge in a ureter, causing excruciating pain radiating from the flank.
Ouch. What causes them?
Often dehydration, recurrent UTIs, high blood calcium, or alkaline urine. Drinking plenty of water is the best prevention. If they don't pass, shockwave lithotripsy can break them up non-invasively.
Okay, from ureters to the bladder, the storage tank.
The urinary bladder, a smooth, collapsible, muscular sac located just behind the pubic bone. In males, it's just anterior to the rectum. In females, anterior to the vagina and uterus.
How much can it hold?
It's remarkably distensible. Moderately full at about 500 milliliters, but can hold up to 800–1,000 milliliters if necessary. When empty, its walls are thick and folded into rugae, like the stomach. As it fills, the walls stretch and thin.
Rugae let it expand. What's the trachon?
The trachon is a smooth, triangular region on the bladder floor, outlined by the 2 ureter openings and the internal urethral opening. It's clinically important because infections tend to persist there.
Structure of the wall.
Similar to the ureters, transitional epithelium mucosa, a thick muscular layer called the detrusor muscle, 3 layers of smooth muscle, and an outer adventitia.
The detrusor muscle. That contracts to empty the bladder.
Exactly. Now, from the bladder out, the urethra.
The final tube.
Yes, a thin-walled muscular tube that drains urine from the bladder out of the body. The lining epithelium changes along its length.
And sphincters control the exit.
2 of them. At the bladder-urethra junction, the detrusor muscle thickens to form the internal urethral sphincter. Its involuntary smooth muscle keeps urine in the bladder.
Involuntary.
Okay, then surrounding the urethra where it passes through the pelvic floor muscles is the external urethral sphincter. This one is a voluntary skeletal muscle, give you conscious control.
Voluntary control. Big
Yeah.
difference between males and females here, right?
Yeah, huge difference. The female urethra is short, only 3 to 4 centimeters, and its only function is to conduct urine. Its external opening is anterior to the vaginal opening.
Short and just for urine.
The male urethra is much longer, about 20 centimeters. It serves 2 functions, carries urine out, and also carries semen during ejaculation. It has 3 regions: prostatic, intermediate, membranous, and spongy urethra running through the penis.
Longer dual function in males. Does the short female urethra cause problems?
It's a major reason why UTIs are much more common in women. The short distance and proximity to the anal opening make it easier for bacteria, usually E. coli, to reach the bladder. Intercourse or spermicide use can also increase risk.
Symptoms are like burning, urgency.
Yes. Dysuria, painful urination, urgency, frequency, sometimes cloudy or bloody urine, usually treated effectively with antibiotics.
Okay, now the actual act of urinating. Micturition.
Micturition or voiding. It requires 3 things to happen at once. The detrusor muscle contracts, the internal urethral sphincter opens involuntarily, and the external urethral sphincter opens voluntarily.
Coordinated effort. How is it controlled?
In infants, it's a simple spinal reflex. Bladder stretch triggers signals that excite parasympathetic nerves, causing detrusor contraction and internal sphincter opening, and inhibits sympathetic nerves and somatic nerves to the external sphincter, causing it to relax. So, automatic emptying.
Reflex in babies. What about adults?
As the nervous system matures, brain centers, particularly in the pons, develop. There are pontine storage centers that inhibit micturition and pontine micturition centers that promote it.
Brain overrides the reflex.
Oh, essentially, yes. When the bladder fills, stretch signals go up to the pons. We become aware of the urge to void. But the storage center allows us to consciously keep the external sphincter closed, delaying urination until convenient. When ready, signals from higher centers allow the micturition reflex to proceed.
So conscious control develops, but sometimes that control is lost.
Yes. Urinary incontinence, the inability to control urination. Stress incontinence is common, leakage during laughing or coughing, often due to weakened pelvic muscles. Overflow incontinence occurs when the bladder overfills. Neurological issues can also cause it.
And the opposite problem, retention.
Urinary retention, inability to expel urine. Common after anesthesia when the detrusor is temporarily inactive, or in older men due to prostate enlargement constricting the urethra, may require catheterization.
Okay, last bit. How does this system develop and change with age?
Embryonically, we actually form 3 sets of kidneys sequentially. Pronephros, mesonephros, and finally the metanephros, which develops into the adult kidneys. These kidneys start lower down and ascend to their final position.
3 kidneys. Wow. When do they start working?
Fetal kidneys are excreting urine into the amniotic fluid by the 3rd month of gestation, although the placenta handles most waste exchange.
And after birth, any common issues?
Congenital abnormalities can occur, though they're mostly uncommon. Horseshoe kidney, where the 2 kidneys fuse, is usually asymptomatic. Hypospadias in males involves the urethral opening being on the underside of the penis, usually surgically corrected. Polycystic kidney disease, PKD, is a genetic disorder causing cysts that impair function, with different forms appearing in infants or adults.
PKD can be serious.
Very much so, often leading to renal failure.
What about aging?
Newborns void frequently small bladder, less ability to concentrate urine. Voluntary control develops around age 2 to 3. UTIs are common infections throughout life. With age, kidney function generally declines, some nephrons are lost, GFR decreases.
Bladder changes too.
Yes, bladder size and muscle tone can decrease, leading to more frequent urination, nocturia, especially at night, and sometimes incontinence.
So a gradual decline is typical.
Unfortunately, yes, though lifestyle factors play a role.
Well, that's an incredible journey through the urinary system, from filtering hundreds of liters
To meticulously reabsorbing almost everything needed.
and then fine-tuning that final product. It really is the unsung hero of our internal environment.
Absolutely. It's far more than just waste removal. It's about maintaining that delicate internal balance, that homeostasis, that allows every other cell and system in your body to function properly.
So complex, yet so vital.
Which does raise an interesting question to ponder. Considering how critical water and ion balance is for literally every cell, how might a seemingly small malfunction, maybe just in the nephron loop's ability to pump salt, have really widespread cascading effects on other body systems, effects you might not immediately connect back to kidney health?
That's a great point. Something to think about, the interconnectedness of it all. Thank you for joining us on this deep dive, and thank you, our listeners, for being part of our last-minute lecture family as we explored the incredible world of human anatomy and physiology.